If everybody take their seats at some point, we'll get started in just a minute. So my name is Will Harris. I'm one of the vascular surgeons at VIC. Thanks for all attending today. Really happy to have all of you here to talk about peripheral arterial disease. Dr. Lassar knows my penchant for history. I'm a huge history buff. I make my children drag them to the Civil War battlefields all the time, and they hate me for it. And so he asked me to talk a little bit about the history of treatment of peripheral arterial disease, which I think is fascinating because I learned things at the same time. So peripheral arterial disease affects, as we've discussed over and over and again, between 27 million, 40 million people within Europe and North America. Interestingly enough, claudication was first described by a French veterinarian. This is what I learned. And he was describing it in horses who had occluded femoral arteries and were having trouble walking short distances. So I assumed the horse was had a penchant for cigarettes. And then Charcot, who everybody has heard the name Charcot for a multitude of things, he was a French neurologist. Charcot actually was one who coined ALS, or he discovered or termed ALS, as well as a multitude of other things. He termed it leg effort angina in humans. So further research identified inflammation in the vessels as being the cause of atherosclerotic disease. And then a pathologist actually found inflammatory cells within vascular plaques, identifying the pathophysiology of atherosclerotic disease. And Virchow actually described the triad of intravascular wall damage, the stasis of flow, and a hypercoagulable state. In 1908, Mr. Osler, who was a surgeon, he was one of the surgeons who founded Johns Hopkins. If you actually go to Johns Hopkins and they say you do rounds, Johns Hopkins actually has a round oval area, and it had 4 corners, and it was for each one of the 4 surgeons, so they could do rounds in different corners of the hospital in the original building. He discussed and identified the impact of inflammation and infection in the pathogenesis of atherosclerotic disease. So, and then interestingly enough, it took an orthopedic surgeon to really identify the fact that those with peripheral arterial disease had a significantly reduced life expectancy. So I think it's interesting to look at the evolution of medical therapies most commonly used in the treatment of peripheral arterial disease. Heparin was actually discovered in 1916, but it wasn't purified until 1933. It's one of the most common agents that we actually use in the operating room for anticoagulation during the procedures, but it wasn't exactly utilized in this method until 1937. But you have to remember, arterial reconstructions were in their extreme infancy at this time. Aspirin, interestingly enough, was produced by a chemist in 1853. So that's the most commonly used drug in vascular surgery. All of our patients should be on aspirin, despite what the New York Times says. And it took him about 50 years to establish efficient production methods, but it's been on the market for that long. And its anti-inflammatory effects and antiplatelet effects have been known since the early 1900s. So anticoagulants, I think it's interesting to talk about one of the most commonly used anticoagulants that we use, that at least was used prior to the advent of novel oral anticoagulations. In 1921, cattle were found to ingest a moldy hay, and they hemorrhaged to death after simple castrations or removal of their horns. And they did a deep dive into these cattle and identified the precursor to Coumadin. And so initially it was produced as a rodenticide, so it really was rat poison. Then multiple Army soldiers in the 1950s apparently weren't happy with their quality of life, and so they tried to commit suicide with it. They were treated in Army hospitals with vitamin K, but somebody had the bright idea and saw the hemorrhagic effects that maybe we could use this as an anticoagulant. And so in 1953, I believe, it came onto market as an anticoagulant, and it was actually prescribed to Dwight David Eisenhower, who was a heavy smoker and had multiple heart attacks, even during his administration and after his administration. And it was prescribed to him in 1955. So advances in surgical care, I think it's interesting to realize that we've only been doing this for less than a century, vascular surgery, in its present form. You know, the first use of venous autograft was in 1906 to replace a patient with syphilis that infected into the popliteal artery. And then in 1948, a French surgeon actually described using a vein to bypass occlusive disease. However, this didn't really take hold until later in 1955, in which a couple of Harvard surgeons published their results of a small series of vein bypasses in the journal Surgery. And then in 1962, they started using vein patches for artery, for opening up arteries. And then the advent of DeBakey. DeBakey is kind of legendary from a vascular standpoint. He was famous for doing a fair number of heart operations, but also replacement of aortas. And he was the first person to really take a piece of synthetic material and replace an aorta with this synthetic material. He initially actually went to the store, a fabric store, to buy nylon, and they were out of nylon, but the fabric owner said, hey, we have this new material called Dacron. And so he took Dacron home and fashioned it himself on his mother's sewing machine. And then one of his patients turned out to be a sock maker. And he enlisted the help of the sock maker to weave the Dacron together to use it for aortic stent graft, the first aortic stent grafts, or aortic grafts. And he did open surgical bypasses with these aortic grafts. So up until then, we started using, up until the 90s, we used Dacron with some regularity for surgical bypasses in patients who had no vein. After that, we started using Gore-Tex. So the same stuff that waterproofs your jackets we'll use for surgical bypasses now. The biggest problem with these bypasses, if we use these synthetic conduits, is they are prone to infection, and their long-term results are nowhere near as good for especially below-knee surgical bypasses as vein. I would be remiss, having been in the Air Force myself, to not discuss the role of military issues in dealing with vascular surgery. The control of hemorrhage is described from the 2nd century on, and up until then, for years they were using cautery, oftentimes like a branding iron or hot burning oils to cauterize the tissues. It wasn't until the 16th century that somebody had the idea of using some sort of suture or silk to actually ligate a bleeding artery. The fascinating thing about this is this was the standard of care to treat a bleeding vessel all the way up until the 1950s, which is somewhat sad. So even through World War I, World War II, with the advent of trauma surgeries, there was not really good arterial surgical interventions. I think during World War II, DeBakey did a retrospective paper and found only approximately 80 arterial repairers in the whole war in the U.S. side. This increased in Korea. They started to focus on attempting to intervene on arterial injuries, and by the time of Vietnam, the limb salvage rate had improved to 87%. And so an arterial repair was becoming standard of care. And now in the modern battlefields, especially in Iraq and Afghanistan, our limb salvage rates were well above 90%, 95%. Part of that is secondary to, access to care and things like that, and modern evacuation techniques, but a lot of it is surgical training. So the advent of minimally invasive surgery for what we do day in and day out, what I've been doing all morning, what I'll probably be doing all afternoon, starts with the Seldinger technique, which is where we access the blood vessel in a minimally invasive fashion. And this was described initially in 1953, where we access the artery with a needle and run a wire into it and then sequentially dilate the vessel over the wire. And everything we do is over a wire. A wire is holy. If you lose a wire access, you lose a lot of points. So in the late 1960s, they started describing dilating blocked blood vessels with sequential dilations of catheters. And then a gentleman named Fogarty actually developed a balloon on the tip of a catheter, and the original design for it was to pull out clot of arteries so you wouldn't have to cut down directly over the artery to pull out clot. Dotter and Fogarty actually worked together to develop balloons, elastic balloons, to actually start beginning the basics of angioplasty. So a Swiss interventional radiologist, or radiologist, there was no such thing as interventional radiology at that time, first described in 1974 the use of a elastic balloon to perform an angioplasty. And then we all know that angioplasty is not as good for long-term patency data as actually stenting something. So in 1985, Palmaz actually developed a metal scaffold structure. And if you had discovered a stent like this or brought something like this onto the market, you too could own a vineyard in Napa that produces $150 bottle wines. What's that? Oh, did he die in a plane crash? Oh, Gronzing did, yes. I was going to say, I think Palmaz is still alive. He's still consulting, believe it or not. He gets royalty fees from Cordis. But then you have to talk about even further developments of balloon-mounted stents and whatnot. And so in 1990, Juan Perotti, he's somewhat legendary in a vascular surgery standpoint, mounted on one of these Palmaz balloon-mounted stents a piece of Dacron graft and advanced a large catheter into the aorta to treat an aortic aneurysm on the president of Argentina. And so this was the first aortic endovascular stent grafting. So techniques like this, technology like this is the basis for modern vascular surgery, angioplasty, stenting. So it's pretty neat to go back and look at how far we've come and whatnot, just in a short course of time. So this is what my kids think about history lessons. With that, I'll introduce, I think Dr. Ferrer is next. Lucas is a vascular surgeon in Austin, Texas, and is here to discuss more modern techniques of intervention on peripheral arterial disease.
All right, thank you. So we're going to talk a little bit about more kind of extreme limb salvage, or kind of what's the cutting edge technology at this point. This is kind of one of my, interests in research, and we'll talk about foot vein arterialization, which is kind of a hot topic right now in limb salvage. So disclosures. So we'll talk about the basics, what is PAD and CLTI, which we've talked about a little bit, the anatomy, and then kind of go into some pictures of outcomes and some data. So the basics, so we have the kind of normal basic arterial anatomy, which we're kind of familiar with, but there's another anatomy that we need to learn when we start talking about arterialization, and this is not so basic. It's people have a lot of variations, and it's kind of something that, to be honest, we didn't really look into in residency or fellowship, and it's something that we kind of have to learn in the last few years. So what's the problem? So nearly 2 million people are living with limb loss in the United States. The main cause is vascular disease. More than 50% of these people lose their legs because of vascular disease. And we do about 200,000 amputations in the US a year. So that's a large number of people suffering from this. And the problem, obviously, is increasing, as we know from our daily practice. So in atherosclerosis, or PAD, we kind of have to start having some nuances. So we have something called big artery disease, which is basically plaques in our known major vessels, including tibial vessels and pedal vessels. And when you have enough disease burden, usually at multi-levels in these vessels, then you have enough loss of blood flow where your limb starts to become compromised. But you need kind of several levels of disease to reach this. And there's a kind of subset of patients that are your severe diabetics, end-stage renal patients that start having complete destruction of their small kind of metatarsal vessels, the small vessels in the foot. And these patients don't need to have multiple levels. They can just have obliteration of the vessel that goes straight to the toe, and this by itself can lead to tissue loss and limb loss. So currently, we have no, or until recently, we had no effective treatment to treat this kind of small, what we call small artery disease, or commonly known as microvascular disease. So most of these patients just got amputations. So what options do we have? So a long time ago, a lonely Chilean doctor in a military hospital that started to develop this technique, which had some history before, but he kind of, conceptualized it of foot vein arterialization. And he developed his own instruments to do it, moved to France, and then kind of popularized it in France. And his name was Dr. Lengua. And basically, he achieved a 60% survival rate by doing a bypass to the greater saphenous vein, and then with some instruments he developed, breaking those valves into the foot, driving blood flow, arterial blood flow, into the venous system of the foot, and basically achieving limb loss. There was no mechanism described at that point. There were some observations that new blood vessels were formed, but the reason why, we still really don't know to this day. But this was kind of brought back recently, and we started doing this procedure through endovascular fashion. And there was one study that was a PROMISE 1 study where a company called LymphFlow developed this kind of proprietary stents and instruments to do this in endovascular fashion. And they replicated the 60% limb salvage rate at 1 year that Dr. Lengua had done many years ago, but in a kind of more modern fashion. And here you can see some data from the PROMISE 1 trial. Here you see that the wound area on the foot starts decreasing over time after the procedure. And here you see an increasing healing status over time also. And here you see another trial where they look at TCPO2. So TCPO2 is the amount of oxygen you can measure transcutaneously. And you can see that after you do this procedure, at about 90 days, you plateau at a higher level of TCPO2. So something's happening in the tissue where you have more oxygen. And as I said, to this day, we really don't know the mechanism. There's several proposed, but we're kind of actively studying why at this point. So how do we do this? So this is this is from kind of the LymphFlow company, but you can do this basically with off-the-shelf equipment that we have available. But this is kind of the proprietary data. You basically go into the artery up to the point where it's usually blocked. Then you also access the vein in the foot, and you cross from the artery to the vein, and then stent all the way down from the artery into the vein, into the foot, and drive blood into the foot that way. And here we have, this is one of my patients, so we access basically really far, as far as we can into the forefoot. We take a picture of the venous system, we map it out, and kind of strategize where our crossing area is going to be. We go up into the upper calf, and then you can see some of the venous and arterial anatomy. In this patient, we went from the peroneal artery into the posterior tibial vein as our crossing area. And after we have through and through access, we balloon the entire venous system, we place a stent, we balloon the arch, which connects the upper venous system and the deep venous system, or superficial venous system and deep venous system. And at the end of the procedure, you have blood flow into the venous circuit. Now, this by itself doesn't improve tissue perfusion, doesn't improve oxygen delivery, but it starts a process where you have additional recruitment of the smaller venules, and eventually you have new arterial formation. So new small arteries start forming, which is really interesting. And here is one of my I think this is one of the first patients I did. This is a young, like 46-year-old teacher who basically was going to have an amputation, was going to have to lose his job. And after lots of work, we were able to basically save his limb. He was able to walk, he was able to continue teaching, and we were able to save his foot. And here are some more patients. Let me see, I have that left is a video. Can you play the video? Let's see. Yeah. And there's some sound there. I don't know if you can. So that's arterialized flow in the venous circuit in somebody that had a complete desert foot. And this is another 50-year-old truck driver that was going to lose his job and not able to provide for his family. And now, he's able to continue working and being productive in society. So take-home message, this is kind of a nascent field. We recently, in Austin where I work, we were participating in the Promise 2 trial, which the data got published this week at one of the major conferences in Viva, and we were able to replicate the initial small trial in a multi-center international trial with 20 sites, and we were able to replicate the 60% limb salvage rate and the 40% wound healing rate. Still, we don't have a mechanism of action, but that's something that we're actively trying to study at the moment. But this is kind of the cutting edge right now in limb salvage, and it's a very exciting area because there's still so many questions that are left to be answered. So.
So we've seen, this section's on critical limb care, and we've seen kind of the history of how Vascular started really not that long ago, and now we've seen the future of where we're going, some of the great work Dr. Ferrer is doing and his group. And I'm going to talk about the next section, which is kind of like what we do every single day, and this is a lot of the more advanced endovascular care for patients with critical limb disease. So, we've tried to develop a center of excellence for PAD-CLI, really believe in trying to save people's legs and then restore their lives. And our mission is really victory over amputation. So kind of a catchy little thing, that's why we call it VIC, but that is really what we're trying to drive home for the region. And, amputation surgery is appropriate in some people, but it's not appropriate if you stub your toe or if you have maybe a little area of gangrene on the tip of your toe. You don't need to have an amputation of your leg. And a lot of times that is really the process that people go down for, and we have a lot of high rate of amputations in this region. And so our limb salvage rate at VIC over the last 5 years is 97.4% at 6 months. So we're changing the course of that patient's trajectory in that early phase. But understand, we still do a lot of amputation work in the hospitals. It's because things have not changed necessarily on that front. Patients are still developing advanced disease. They're coming into the hospital with a no-win situation for these patients. So in my mind, that means I still have work to do in the region to say, okay, look, we need to identify these patients early because we can save their legs if we get them quick enough. So this is a test question. I try to keep this a little bit exciting, at least thoughtful. Which foot here is ischemic? I love the toenail polish. I think she did a great job. But which foot here is ischemic? Would it help if I said that the right foot, the pain was worse at night? Because then we could actually say, oh, look, that's rubor, that's normal, that's rubor, and she actually has chronic ischemia. Or is it sudden onset of pain in the left in her good leg, and maybe that's actually acute ischemia. And so that's actually what she has. She has chronic ischemia in the right leg, but acute ischemia in this left leg. And I want to talk about that because that's a person I want to phone call. I don't want to get a referral for 3 months from now. I want a phone call now. And this patient, the first thing you'll do is, if they're having severe pain in their foot, you want to do a pulse exam and see if they have an adequate pulse. I think I jumped over one. Let me back up. There we go. So there's the neuromotor exam. And what I want to see is normal on the right, and then wash her toes on the left. The toes on the left just don't want to move. The fourth, fifth, and third toes don't want to move. So normal on the right, abnormal on the left. And so that is the sensory exam. I just touched each side. Does this feel the same? Does this feel the same? Where's the numbness happening? And she pretty much had numbness from the knee down on that left leg. So she had motor is dysfunctional, neural is dysfunctional, and so she has acute ischemia. So we kind of classify that in class 1, limbs viable without therapeutic intervention right now, so it's just fairly mild. Limb 2 is what I just showed you. That's limb-threatening ischemia. This needs to be repaired if we're going to save that leg. And then class 3 is where you have an irreversibly ischemic limb that's just not salvageable. This is a gentleman, 45 years old, who developed severe pain in his foot on a job, and he was working, and he continued to work. Eventually, the pain went away. When the nerves die, you don't feel anymore. And so, but he came in with basically a dead foot, and there's nothing I can do. It's the cat's out of the bag after that. So class 2A and 2B is really kind of where we need to live. If there's something that's urgent, call your local vascular surgeon. Please let them know that you got a pretty sick patient. So chronic ischemia is really kind of what we find kind of every day. We kind of uncover that. A patient comes in with a little black toe, or they can be a diabetic and develop a fairly severe infection of the foot. But these are the typical presentations of chronic ischemia. Now, we tend to want to talk about the same language. So Rutherford class is important. It's how we classify chronic ischemia, 1 through 6. And 1 through 3, class 1, 2, 3 is claudication, mild, moderate, severe. And class 4 is where they have rest pain, and they have ischemia here. Class 5 is they have tissue loss, might lose a toe. Class 6 is they're going to lose part of their foot to save their leg. And so that Rutherford class is important. You call me and say, hey, listen, I got someone with a Rutherford 5. I need to see him tomorrow. Just send him in my office tomorrow. We're going to get him in. So over the last 4 years, what we typically do, I'm going to invite you into surgery and kind of see what we do every day. Actually, what Dr. Harris is doing right now. So he had to go back to do surgery. But this is, we'll prep the entire leg. We access the femoral arteries, or maybe accessed by the foot. Oftentimes we do an ankle first approach. It's simply because patients can walk out of the office after about an hour to 2. But there's advances in technology that allow us to do this. And as the catheters have come smaller and smaller and more tapered, we can actually start to treat patients from the tibial approach. And we think it actually helps us and it helps patients. It reduces the amount of contrast or radiation exposure. It reduces the bleeding complications and lets patients walk home early. So if we use those devices, those sheaths, we can pretty much use all the different tools that we have in our armamentarium and actually treat a lot of these patients. So this patient is a 85-year-old gentleman who came into my office. He had this wound on his right under his little toe for about 6 months. Kind of started gangrenous changes on the tip of the toe. He was in constant rest pain, and he was recommended to have an amputation 6 months before. He refused. He searched around and went to lots of different doctors trying to figure out what to do. Eventually, he got to us, and I said, I think we can fix this and save your foot and not have to do an amputation. And we did an ultrasound showing he had a stent there with some obstruction. He had a blockage in that anterior tibial artery, anterior tibial artery goes to that toe, so I need to fix that spot. And also here is usually a posterior tibial blockage. So I'll be curious if he has that. So right where that wound is where the lateral plantar artery feeds. And we talked about angiosome before, but the angiosome, the flow in that artery to that spot is what I really need to go after. And so we access the anterior tibial artery. I often do this in a sitting position just to get access. And that's kind of our setup. We have fluoroscopy and a team of nurses to help. This is actually what we did. We accessed the anterior tibial, came through and reopened some of the arteries here. So the anterior tibial artery is occluded right through here. We established flow with a device called CSI, who's sponsoring this event here, and they have a device to show you. This is the lesion that was also treated. The stent was actually working pretty well. But afterwards, he has pretty good flow now established in that lower leg all the way to the knee. And from the knee down, the anterior tibial artery is open. But remember that wound on the side of the foot, okay? That wound on the side of the foot is the blood flow comes from this artery right here. So this blockage actually needs to be treated. We kind of went up and over, made a U-turn and angioplasty that open. And at the end of the operation, we actually have significant blood return. So I don't show that to shock anybody, but that's the amount of perfusion that's actually coming through that vessel, per second. And if we can establish that blood flow, this foot's going to start to heal. And after about 4 weeks, he healed all his wounds and moved on. So that's the typical process. Now, we talk about being CLI fighters. We took that pretty literally here. But what to do takes longer to learn than how to do it. Training somebody how to do it is easy. When to do something is actually the hard part. And, you have to have the right tools to be successful for these patients. You have to do things to prevent complications. Alternative access is important because it helps patients move faster with lower complication rates. But adequate perfusion is really what it's all about to me. And so oftentimes what we do is we insonate or check with ultrasound the different zones in the foot. We actually look at the little arteries in the foot. We look at the waveform pattern there. And if they have fairly normal waveform patterns where the slope is, during systole, is fairly vertical, that means there's no blockage between the heart and that point. If that slope is very vertical, that waveform is very clean, that means the flow in that artery is adequate. If that waveform is flattened out, that means there's a blockage in that artery. And so we can classify this, and we can use that to actually help our patients predict whether they're going to heal or not. So this is a patient that is 81 years of age, diabetic. He had progressive gangrene to his right toe. He has diabetes. He is a former smoker, quit 40 years ago. He had a palpable femoral pulse, popliteal pulse, but no pedal pulses. And so we looked at his foot here. This was a blister that then eventually over 2 weeks turned into gangrene. We did a non-invasive ultrasound test to see what was happening. He had triphasic femorals, but monophasic distal. And we did the PAT assessment. That's where we look at the foot arteries. We classified them as class 3. That's what we call severe insufficiency. And we did an arteriogram, and this is what we found. We found that both anterior tibial and posterior tibial arteries were occluded, perineal was occluded. He had no straight line flow into the foot. And so on the angiogram, you can appreciate that the artery comes in, this is the perineal artery, but then it basically blocks, completely blocks. So this is the main artery going into the foot, and then that's blocked. So we use a little roto-rooter device and actually clear that out and reestablish flow now into that posterior tibial artery that feeds the arch. And at 1 week, what I see on the physical exam is that the bottom of the toe is actually starting to heal. There's granulation tissue, the skin's starting to grow and maybe slough off a little bit, but that's signs of healing. Anteriorly, we see something called a line of demarcation, and that is where what is alive stays alive and what is dead dies. And that's what happens when you have ischemia. This great toe, because of that line of demarcation and the tendon showing, tells me that it has to go. That can't be saved. That's moved on to death. And so then that's when I call our podiatrist to actually help fix the patient. But what they want to know from me is, hey, does he have enough circulation that my surgery is going to heal? And I did a study after this procedure. He's back to class 1 normal circulation. So I referred at that week to the podiatrist for the amputation because at this point, he should heal. And he did. Everything healed very well. At 3 months afterwards, his circulation in the foot, the PATs are back to still staying normal, and he's ambulating again, with the foot and doing well. So for me to be successful at this, it's not just me. It has to be a community. It has to be a community effort to do this. Identify patients, get them in quickly. I do the plumbing. Podiatry does the carpentry. That's how it works. And we work together very closely for limb salvage. And so if a person lands within the circle, they have CLI in this community, whether it's from primary care or endocrine or podiatrics or infectious disease, whoever finds the patient, they're in the circle. And what we need to do to improve limb salvage is connect to an interventionalist and connect to a podiatrist. And that's what's going to save the leg. And if we know that if we save the leg, we actually improve their ability to live longer. And so saving, renewing lives is a community approach. And I thank you for your attention. So we are currently, I believe, ahead of schedule. So I appreciate everybody's hard work on that. There is, since we have a few minutes, is there any specific questions that I can answer, or Dr. Ferrer can answer, that you might have? Yes, ma'am. Yeah, so that's a good question. So what you're asking is access to care. And we have 5 centers in the region for access to care. But we also have a policy, and we have enough personnel on our team to get somebody in immediately. So I've had a number of times where a wound center doctor calls me and says, hey, listen, I got a really bad problem. And I said, well, send them to our office today if they can, or tomorrow. We'll get their ultrasound, tell them not to eat. They might go to surgery that day. And so that's very common when you have this kind of level of disease. And so I work really closely with podiatrists. Our team does. And so they may call me and say, hey, we got somebody that's in trouble. Or you call me and you identify someone with acute ischemia, like that I showed you that first patient with the painted nails. Phone call or text us or let us know that hey, you got somebody that's really critical. We'll get them in immediately and treat them. That's how we're going to save their leg. If they have to go through a referral process that takes weeks, by the time they get to me, it's too late. Everything's gone. The podiatrist can't do anything because it's the bone's infected. So the only way to win is to get these people in immediately. So we do have a policy. Any consult, less than 3 days, can be seen. And for critical patients, call, we'll make it happen.
What if someone goes I work for an urgent care, but
Sure.
we also do primary care.
Yep.
And I say that to say I have patients that I can see and send them to you, but a lot of patients currently with finance, insurance, or whatnot, so if they're coming in and can't be seen in the urgent care to send to you, do you guys have a walk-in process? I know you said no referral needed, so they can just walk in and kind of schedule themselves?
Yep, they probably could. It'd be nice to have at least to organize their ultrasound testing to have that scheduling ability. But we'll take anybody that comes in because it's that dire. We also have a program through the Hamilton County Medical Society. We've worked very closely with Project Access in the past. So if they qualify for Project Access, we can get them in and get them care. And those are people who just don't have enough finances. And then we have some patients that are just destitute. And we have a program where we can pay for their surgery through programs like this that raise money, or the run that we do during the year that raises money so that their surgery can be completed and we can save their leg. And so there is that resource available.
One more question. No, I know I'm familiar with Project Access, and I know that there are limitations as far as patient qualifications based on whether or not they're diagnosed with hepatitis or they smoke marijuana or things like that. So outside of that, Project Access, do you guys have other resources for patients that do not qualify for Project Access?
Yes, and so that was the net that I was talking about.
Okay.
So we do have the ability, if someone came in with critical limb, we can fix them in our procedure center. The funds pay for the products that we use. A lot of times the products are donated from the companies. We're always going to try to fight for that patient, and no patient should not have the treatment they should have, that they need. Fair enough? All right, so I want to stay on time, and I want to introduce our next section, which is our podiatric specialists in the region. A number of great doctors here, great surgeons, and it's important to understand about foot care, foot dynamics, and how they think about it so that we can care for our patients. So I think our next physician is Dr. Pacheco. Please introduce yourselves and